Okay, so let's review anti-inflammatory drugs. Those are NSAIDs. So in the previous few minutes, in the other audio slash video, we talked about the pathophysiology itself. Um, so, so if you look at the bullet points here, it tells very clearly what are the purposes of using NSAIDs. That's analgesic, anti-inflammatory, that's like arthritic pain in any type of joint pain, antipyretic for fever, right? And then aspirin usually is not classified under NSAIDs, but some people do. So we could keep, your book says so. So we'll keep it here as in aspirin, which is particularly a platelet inhibitor. So the reason someone could be given an NSAIDs are all listed in the second bullet point, and then we talked about how they inhibit the prostaglandin pathway, or sometimes the leukotriene. But for now, we're going to focus on the prostaglandin pathway, and how they do it is by blocking the activity of the COX enzyme, that's a cyclooxygenase, right? And we talked about two types of inhibitors, the COX-1 and COX-2. And we talked about the drugs that come under COX-2 inhibitor. And if you look here in this table, COX-2 inhibitors are celecoxib. And we did, so if you remember the coxib, if it ends with a coxib, even if I test you on a different name that ends with a coxib, I would assume you'd be able to know that it's a COX-2 inhibitor, right? So if you look at COX-2 inhibitor in that third row, it's given for osteoarthritis, rheumatoid arthritis, and primary dysmenorrhea when women are, girls might have painful menstruation. So, however, there are several side effects with that for some patients, particularly when they're given this, they could have heart or renal or lower extremity edema. So diarrhea is like GI side effects, right? Hypertension, because these COX-2 enzymes can also work on the blood vessels, so the smooth muscles. So it's important to know, that there was a black box warning before, and those are selective inhibitors. Okay, so then if you look at the COX-1 inhibitor, we talked about diclofenac and ketorolac, and then also ibuprofen and naproxen. This row should have come earlier on. But if you look at those two rows, the acetic acid derivatives and the last one, these drugs are usually given for, again, for pain relief, right? Analgesic, and for inflammation, again. So the things to remember in these are that naproxen has fewer interactions with these inhibitors, so it can be given safely when patients have hypertension and they're on ACE as well, versus ibuprofen can have GI complications and also be toxic for patients with renal problems and heart problems. In the long run, again, most of the drugs, if given for more than 3 months, averagely studies have shown that they're more toxic. I mean, you probably heard, people or grandma saying, "Oh, I take this every day throughout my life," right? Well, if they don't have renal, GI or heart, it's okay, And again, not every drug is toxic to everyone. There's so many factors, we sometimes, there's a risk. There's always a risk when patients have these problems. They might, if they take it long term, they could have some things. Not everybody will have it, right? So with that said, with ibuprofen and naproxen, so you should know that it's a COX-1 inhibitor. They're non-selective. So are ketorolac and diclofenac, which is the Voltaren. So one important thing to remember when you see patients is that patients might be taking things like warfarin or Coumadin, right? Or they might be on steroids, like corticosteroids. So in those conditions, you have to be really cautious and not have them take these at home, because the risk of bleeding is even higher. So that patients are on corticosteroids and or warfarin / Coumadin, which is a blood thinner, which we kind of talked about hemostasis part, right? The prostaglandin help with hemostasis, right, with clotting. So we don't want their blood to be too thin or cause severe GI bleeds. Okay, so that's something to keep in mind. As far as aspirin, which is a salicylate, You probably have heard of this being used for as cardioprotective effect when patients are post-MI or post-stroke, because they help with inhibiting the platelets, which was not found until like the past, I think, 2 decades or so. Initially, aspirin was, was found to just help with, and antipyretic, meaning like fever and pain, right? So of late, they've identified in baby aspirin of 81 milligrams given for patients with post MIS prophylactic and post stroke if they're not having any hemorrhagic issues. So one thing to remember with the aspirin is to not to give children below 12 years of age, because it could potentially cause something called Ray's syndrome, where the child might have severe vomiting, drowsiness, and fatigue. Even in teens, we need to use with caution. So read the book on updates. I think your book is pretty updated with the side effects for these drugs. So from the exam point of view, you could be expected to be tested on these COX-1, COX-2, and interactions with Coumadin corticosteroids, and of course the aspirin in terms of Ray's syndrome. Okay.